Hello everyone. Welcome to today's phlebotomy webinar on tips and tricks for difficult sticks. This is Heidi Zunker, an Education Program Manager for Mayo Clinic Laboratories. Our presenters today are Randy Grilke and Danny Grabow, both instructors in laboratory medicine and pathology at Mayo Clinic in Rochester, Minnesota. Just a couple of things to remind everyone before we begin today. There will be a question and answer session at the end of the program. You can submit questions online via the chat function, or following the presentation, phone lines can be unmuted to ask a question. Today's program is being recorded and will be posted to our website in a few weeks. I'll now turn the phone over to our presenter.
Thank you, Heidi. This is Randy Grilke. As Heidi said, both Danny and I will be presenting today, and we'll kind of alternate, bounce back and forth between slides as we move through the presentation. We are both phlebotomists, many years, but some of us, Danny may have a little bit more expertise in one area than I. We do have quite a list of questions that were sent in prior to this presentation, and we will move through our presentation and hopefully get to these questions and or answer the questions that you have, because we are then delivering to you what you need based on the specific questions that you have. So we will go ahead and get started, and hopefully we leave plenty of time to answer the questions that you have today, as well as look at some of the questions that were sent in prior to the presentation. There's an excellent group of questions here as well. So again, thank you for joining us, and we'll go ahead and get started. We don't have anything to disclose. In fact, if you viewed the PowerPoint ahead of time, you notice there are no pictures or anything in there. We are not going to affiliate ourselves with any particular manufacturer's equipment. The objectives today is to describe some specific situations that are likely to increase the level of difficulty in the collection process. So tips and tricks for difficult collections, as most of you or all of you are aware, getting the blood is only part of being successful, because we'll also look at some equipment choices that are best for specific collections, particularly focusing on making sure that once we get the blood, we actually have a high quality specimen, one that reflects the actual current status of the patient at the time of the collection. And we'll look at some techniques that can reduce the level of difficulty during a phlebotomy draw. We do recognize that the audience has a vast range of experience. We also know that you recognize that one person's difficulty is not necessarily another individual's difficulty, but hopefully between some of the tips and techniques that we share will not only help you in collecting some of these difficult patients, but again will also allow us to send a quality specimen to the testing lab. When we look at difficult collections, there are a couple primary categories, and the largest one is physiological factors, things like vascular conditions that the patient has, sclerosis, cancer patients being treated with chemo, former or current drug addicts, their critical care patients in the ICU, the ED, the trauma areas. We have edemesis patients, we have obese patients, elderly, and pediatrics. And elderly and pediatrics can encompass an entire presentation on its own. We also look at some psychological issues, and we're talking things about needle phobia, and then combative patients, pediatrics or elderly, those that are confused or medicated. Vascular scarring, the first thing we'll look at, and we will visit some of these also later in the presentation as they present themselves with particular or specific unique patient situations. Vascular scarring, we're looking at things like atherosclerosis, again, drug addicts, former or current chemo patient. Oftentimes we don't have difficulty in finding the vein, but the scarring of that particular vessel will actually cause us some degree of difficulty in getting the needle in the vein. Those veins jump. You hear patients tell us they roll. We know they're not down there physically rolling, but they do move. And this can be compounded when the vessel is scarred. The needle will actually struggle to enter the vessel and push it off to the side. So some tips to help prevent that. You notice that first bullet point is underlined because anchoring that vein is crucial in helping to get that needle through it. Where to stick when we access or palpate a vein that we can feel is quite hard from scar tissue. Oftentimes, while we're palpating, we go above the scarred area and we feel great bounce. And so the inclination is to stick there, and in reality, that is not the best place to stick. Recognizing the blood flow as it flows through the arm is up towards the heart. So trying to get the blood from a scarred vessel above the scarred area actually is difficult to do. We're better off going below. Look below the scarred area. That way the blood flow is not impeded. We're able to successfully collect the specimen. So on individuals like this, go low.
Critical care patients, like in the ICU, the ED, trauma patients, we have to worry about different things when it comes to them. A lot of times it's difficult to palpate veins there. So we use different things like heat, even gravity. We use that to our advantage. We use different equipment like blood pressure cuffs. There's different techniques you can use there. Transilluminators, vein finders, everybody calls them. If you have one of those, sometimes they come in handy. Repeat punctures, you got to worry about hematomas. That increases chance of contaminating your sample. And what do we need to do about that? How can we still use that area, and what equipment do we need to do that? Avoid going above swelling or scarring, having blood flow hampered. What's best? What's best for that patient? What's best for a quality sample? Injuries, incisions, we have to worry about that. Some people forget, they'll move an arm a little bit, they might have chest surgery or something like that and cause that patient a great deal of pain, or shoulder surgery. We always got to be looking at those sorts of things. Sometimes we can't use the arms due to lines or injuries or surgeries or whatever. We have to get a foot stick order. You have to follow your institution guidelines there. It's just different things you need to look at and look at the whole thing. Limb restrictions. You never want to use that limb for any reason, for any collection. Utilize the other limb if you can. Go to that one right away. If you do have to go to a foot stick, you'll want to contact your provider.
Yeah, just to reiterate what Danny was talking about there in regards to limb restrictions, recognize that the most important thing here as we move through this presentation is please, follow your institution's policies and guidelines. What we share in this is not the end all to everything, but recognize that a limb restriction is just that. It's not a limb restriction for like IVs or line placement. It's a limb restriction for venipunctures. It's a limb restriction for even a capillary collection. And one of the suggestions was a foot stick, as Danny said, contact the provider prior to performing a foot stick. And I would suggest that when you do contact the provider, if they do give permission, to please ask them to document that. Please ask them to create an order, put it in the patient's medical file so that not only are we sure it's there, but any of our colleagues that may come later in the day to collect a specimen from that patient, it's there as well. Central venous lines, this is one in which I know there's a lot of variances. Perhaps in your institution, in the hospital areas, phlebotomists might not even be present. Here at Mayo, we have phlebotomy present during the central line collection. The nurse does indeed do the actual collection. However, here, the phlebotomist is responsible for not only identifying the patient, but retrieving the order, printing the labels. And they're also trained, we train our phlebotomists to know what they need to know from a line collection so that they can help the nurse, so they can intervene if they should see something that is being done incorrectly to make sure that we get a quality specimen. The first thing we look at there is drawing from IV starts. I know that's a very common practice. I also know from past experiences in presentations, questions that were raised, the concern with hemolysis, and that is significant. There's been many studies done. You can certainly easily access them by Googling them, and you will find that there is a 5 to 20+% rate of hemolysis that occurs with IV starts. We've been successful here reducing that significantly, and the success was the fact that we are now requiring a waste. So upon the start of the IV, the insertion of the IV, before we collect any blood for analysis, we require a minimum of 2 mils of waste to be drawn off that IV start before we actually will accept any blood for a sample. When we look at indwelling catheters, central venous lines, long-terms, short-terms, PICCs, IVADs, we have a couple things that we're really concerned about. Number one is contamination, and that's typically due to previously infused infused products, whether they be fluids or medications. Certain infusions, particularly things like dextrose, TPN, or anything that would antibiotic assays, things of that sort have a real tendency to dwell in the lines, and we know that this was focused, and the presentation is focused primarily on difficult collections. But those of you that are involved with lines, even though they're not a venipuncture, there's still some things to be watchful of, especially if you're present during the collection, and that's to assure that we draw sufficient waste to avoid any potential contamination, and then also monitoring the actual collection process when the nurse draws the specimen. And I'm not so concerned about how aggressive they are in using the syringe and pulling on the plunger when they're drawing the waste, because sometimes it takes a bit to break free a clot or anything that's plugging the line. However, that type of aggression when actually drawing the sample is going to be cause for hemolysis, which is our other primary concern when we draw from lines. So be cognizant of the potential for contamination as well as hemolysis.
One other thing I'd like to bring up when we're talking about lines is communication. A lot of people forget to talk to the nursing or the nurses. I like to ask them, have they had any problems when you're talking about how much waste you should do? Have they had any problems with results? Then we want to do a bigger waste. You want to communicate between the nurse and yourself. That's very important, so you get a quality sample.
Next, we'll start looking at some physiological conditions that the patient may present with, and the first one we'll take a look at is edema. Recognizing that the severity of that can run the gauntlet anywhere from minor fluid retention all the way up to extreme distension of the limbs. Edematous patients present some difficulties. First and foremost, finding a vein can range anywhere from difficult to almost impossible. We also have to worry a bit about the contamination, and that contamination comes from all that excess interstitial fluid that's causing that distension, the actual cause for the edematous patient. Some tips: we can certainly use gauze to absorb some of that fluid. we can manually push that fluid aside. And the best way to describe that is to place both of your thumbs in the center of the antecubital area, press down, and then push each thumb in opposite directions out towards the edges of the arm. So you're pushing medially and laterally. And you may need to do this a few times. And I would suggest, depending again on the severity of the edema, that you first try it prior to placing the tourniquet, but have the tourniquet under the arm, ready to apply the tourniquet as soon as you push some of the fluid away. Or on a severely edematous patient, you may actually have to place the tourniquet and then use that pushing technique, that manually moving the fluid away from the antecubital area as you look for a vein. Once we found a vein, we've only solved half the problem, because now we have a place to access, we have a place to collect the specimen. But what we need to remember is all of that excess fluid, when the needle enters the skin, prior to that needle entering the vein, we're going to pick up all of that extra interstitial fluid, and we will fill the needle with that, which is certainly going to cause some contamination of our specimen and will skew test results. Unfortunately, when we're faced with difficult situations, individuals kind of move away from the evacuated tube system and start looking at things like syringes with straight needles, butterflies. There's an issue with those. First of all, using a syringe with a straight needle, you may easily access the vein, but you have that needle full of interstitial fluid that you are now pulling up into the body of the syringe, which will contaminate your specimen, and there's nothing we can do about it. Or using a butterfly, because most butterflies are 3/4 of an inch in length, the needle, versus 1.25, 1.5 inch needles, depending on the size you use at your institution. We simply can't reach the vessel with a butterfly. So the real best choice, the most obvious choice, is the evacuated tube system. I know that's not one we typically reach for in difficult situations, but using that evacuated tube system, we will have a needle that will allow us to reach that vein. And we also have the opportunity then to use a discard tube to rid that needle of the interstitial fluid that will cause contamination and will skew test results. So be cognizant of the fact that getting the sample is only part of it. The other part is making sure we have that quality specimen, and that's where the equipment choices come into play.
Obese patients, palpating the vein can be very difficult because they lay a lot lower. There's a lot of tissue on top of that. Just got to be patient, concentrate with your finger and your brain so they work together. Tourniquet application. One of the things that a tourniquet can do, can roll up and actually cut into the skin. You have to be careful about that. A lot of times we'll take like a washcloth and put around. I've actually seen or heard of techs tying 2 tourniquets together to make it work good enough or be long enough so they can wrap it around the arm. But you got to be careful so that tourniquet doesn't roll up and pinch the patient. One of the things you can do is, it says on here, look at between the creases in the antecubical fossa area. The arm, you can bend it, extend it, do different things so you can feel for that vein. You're going to have to push it a little bit harder usually to get that bounce back because of the tissue in between. But the washcloth wrapped around there, make sure it doesn't cut into the arm. By using the washcloth, you can use the hospital gown, or if they have a light jacket or shirt on, you can go over that. Check the top of the arm, the lateral top of the arm. A lot of times you can find a vein lower down. You can go to a hand vein and look there. You're just trying to find whatever you can find for a bounce. Choice of equipment, evacuated system is usually the best because you can go deeper. A lot of times those veins are very deep. You know, probably almost bury the whole needle with that, or a straight needle on a syringe. Butterfly a lot of times isn't your first choice just because of how deep that vein is. And it, all by feel and your technique, you can determine how deep you have to go with that vein. One thing a lot of people forget is when you're using the evacuated system and you're going for that deep vein and you think you're deep enough, you think you're in it, you don't get a flash. They can pop their tube on, you're not going to lose that vacuum. You get some speckles of blood in there, you know you went through the vein. You know, you want get a blood flow. If you don't get any blood flow, slowly advance it until you do. A lot of times you're right on top of it, you're that close. You just don't know when you've gone deep enough.
And oftentimes, as Danny said, when you pop a tube on and you get a sprinkling or a little flash spray of blood in the tube and nothing more comes, as Danny said, that's a prime indicator of moving through the vein with the needle, because as you enter the vessel, the lumen of the needle will fill up with blood, and you pop that tube on, and that vacuum will pull what's in the needle into the tube, and when you don't see any more blood coming, that's a tip for you to slowly start pulling the needle back, and then once you see blood start entering the tube, anchor down with your device and complete the draw. Next, we'll look at pediatric patients. Some of the challenges with the pediatric patient, we have to include the parents here. They can make or break a collection. We're looking at small vasculature, oftentimes, especially on infants. The veins are very small. Doesn't mean they're difficult to find. It just means as you palpate, you aren't looking for that great return, that great bounce coming back. It will be smaller. And then they can be combative. And so this is a time when you should ask for some assistance and have another technician assist you. Bringing the parents into it is a situation where you need to assess whether or not the parents are capable of assisting, depending on how emotionally overwhelmed they can be. I still am reluctant to involve the parents in helping me hold. I'm much more, or helping with the actual venipuncture process. I'm much more comfortable having another phlebotomist help hold the limb. For example, if we're doing a venipuncture in the antecubital area of an infant, I'm much more comfortable having a phlebotomist hold that arm. We can still involve the parents. We can still bring them alongside and help us with that collection, just their presence being there. When we start looking at how we're going to collect it, the needle size, think small. That doesn't mean that on an older child, somebody that's 12 years old and has a great vein, that we would necessarily have to use a 23 gauge butterfly. I think sometimes we get into stereotyping our patients and we automatically say, oh, this is a peds patient, so I'm going to use a tiny needle, without actually looking at the vessel itself, because as you know, the larger the needle we can use, the better the quality of the specimen will be. So although I do advocate small, don't hesitate to use a larger needle, even a 21 if you're looking at an older child with great veins. Small syringes, the reason I like small syringes is you pull the plunger, you have less vacuum, which means you're going to maintain venous integrity. You won't collapse that vein. As well as there's that risk of hemolysis, but if you aren't aggressive as you're pulling the plunger, you'll be fine. Butterfly needles, I think, are wonderful with children, especially children that are squirming, maybe a bit combative. As you know, you can kind of put that butterfly in that vein and it will float around. It will take quite a bit of jerking and combative moves from the child and still stay in the vein. As it says here, always have assistance, preferably from another experienced phlebotomist to help you restrain the child. I know that isn't always possible. Oftentimes we just simply don't have another tech available, but you should always hope that you can plan that collection with the assistance of another phlebotomist. And then again, involve the parents, ask them to assist, bring the nurse or the physician in if the patients become troublesome, because pediatric collections present their own difficulties. We have a smaller individual, often afraid of needles, often combative, and the parents certainly don't help that collection process if they aren't on board with what needs to be done.
When it comes to the elderly, you got to worry about veins that have already been blown or ruptured. We got to search a little bit harder. It's harder to anchor the veins. We always want to make sure that vein's real tightly anchored. And the other thing you got to worry about is confusion, agitation, combative. You can have all that with an elderly patient. One of the things that helps a lot, or it does with me, is don't be afraid to communicate with them, smiling. I always talk about the duck principle. You got to use the duck principle with peds, elderly, or all patients. Sometimes you're a little confused, you're not really sure what to do or how you're going to handle a situation, but you got to look like you're in control, like a duck on a pond. They float along so in control, but underneath they're paddling like crazy to stay upright. And you do that a lot with the elderly and peds. That's where you use it the most. Some of the tips, you might need to use a smaller needle for those tiny little surface veins or the veins you're going after, the thin-walled veins. You don't want to damage them. Anchoring the veins is critical. You want to grab with your offhand and pull down on that skin to hold that vein in place and make sure you're coming in right on top of the vein. I like to get my body right in line with that vein I'm going to stick. I'm trying not to stick from off to one side or the other. I want to come in right on top of it. So I'm looking right straight down the needle, right where I'm going to stick, and make sure it pops right into that vein. Assistance from another phlebotomist. Some patients get very combative. It might take another phlebotomist, a nurse, doctors, just to keep them under control so they're not moving around, and you might hurt them that way. Needle phobia is another one. You get a patient that has a needle phobia. One of the things you want to ask, and you hate to, but ask right away so they don't get injured, have you ever fainted before when you've drawn blood? So you can lay them back. You know, if you're doing outpatient, you can lay them back in the chair or something like that, elevate their legs to help them so they don't faint this time. As a patient, if they want to tell you, you ask the patient if you want you to tell them, before you stick them. Some patients don't want to know. Children, a lot of techs I know just say 1, 2, 3, and then they poke. Things like that. They don't say things like stick, poke, pinch, or anything like that. They don't describe what's going to happen. They just let them know we're going to draw blood. I'm going to count to 3, 1, 2, 3, and they do it. Don't give them that chance to hear that it's going to be painful. Keep the needle hidden. And when I say that, don't uncap the needle out in front of them and stand there and hold it so they can see it. Just keep it off to the side so they don't focus on that needle and it scares them. Don't tell them you're done until you've popped the tourniquet and taken that needle out of the patient's arm. That patients raise their arms up like, thank God it's over. But, you got to be looking at the safe side of it. When you're all done, it doesn't matter if it's peds, the elderly, or anybody else. Tell them they did a great job. Praise them so they feel confident the next time they come in. Alternate sites that you can use, besides the anacubical fossa, you can look there. You look at the top of the arm. We can use everything here at Mayo from the top of the shoulder to the end of the fingertips. Don't be afraid to use the whole arm. You can use veins up in the bicep area, in the lower arm, on the back side of the arm. A lot of times there's a nice vein back there. The phallic runs down on the thumb side of your arm and the wrist area. A lot of times that vein will pop up. Between the knuckles, a lot of times I've actually drawn blood from fingers, thumbs, and placed IVs in fingers and thumbs. They don't last very long, the IVs don't, but a lot of times you just got to take your time. Sometimes it takes 2 techs to make that work. But you use what you got. Foot stick, you got it. like here, we have to get a order for it. It has to be set up by the doctor. If you have to do a foot stick in the outpatient area, they recommend that the patient keeps that foot elevated for 2 hours afterwards. So you'll have to line up a wheelchair for them to sit in so you can elevate that foot for them. And an escort or a family member to take them on from there.
To reiterate that, it's very common. I mean, I find myself falling into that trap as well. If I don't find anything in the antecubital fossa, I have this tendency to want to go right to the hand. As Danny indicated, we can use the entire arm. So please don't hesitate to, don't just look, actually do some palpation and find bounce with your fingertips as you assess the entire arm, because we are able to do that. We are able to use the entire arm, and don't make that quantum leap from the antecubital fossa straight to the hand. There are many other options there.
Some other techs that you can do is flexing the arm. Lifting the arm may reveal a vein like an antecubical fossa area. Just by bending the arm up a little bit, you'll be able to bounce it sometimes. You'll be able to bounce that vein and feel it. Turning the wrist, one side to the other, that can spread that. Say your vein's right over the top of a tendon, that might move that vein off to the side so you can use it better away from the artery. It's just little things like that can make a big difference. Hyperextending, you got to be careful, especially with the elderly, that you don't over hyperextend it. But if you bend the arm so it's super straight, that'll tighten that vein up and you might be able to bounce it better. But don't be afraid to move the wrist back and forth. It's as simple as that. Leave the arm in that flat position and just turn the hand and wrist left to right and see if that helps. Some of those things will pop right up for you.
Just to quickly clarify something here, as a comment come across regarding the thumb side of the wrist and CLSI recommending not to use it. That's accurate, that's true. What we were talking about is locating that cephalic vein, and a great place to find it is down in the wrist area. Once you find that, you can look for where that cephalic moves into the hand, or return up the arm palpating and actually get away from the wrist area. But finding that cephalic vein is quite easy to find in the wrist area, and then move either down or above from the actual wrist area to make the venipuncture. Thank you for that point that we didn't clarify. Massaging. It's something that's not often done, but massage can certainly help. And what we're talking about with the massage is massaging the arm. Elevate the arm at the elbow, and the key here is actually to massage from the wrist to the elbow. If we're going to look for a vein in the antecube, obviously going in the other direction would facilitate moving blood into the hand vein. So just recognize which direction you are going to be massaging based on where you're looking for the blood. So if you want to look in the antecubital area, then you're going to be massaging with the emphasis on the underside of the arm, using your thumbs and pushing. What you're literally doing is you're forcing blood back up into, say, the median cubital vessel in the antecube, or again, if you have decided that you want to look in the hand, perhaps you found something but it's small, then you can massage in that direction down towards the hand to help move blood into that vessel. That will move blood in there and increase the distension of the vein, or enlarge it, which will allow you to palpate it and find it easily. One technique that I see a number of people doing, and that's snapping with their fingers, particular people that start IVs, and what they're doing is literally they're agitating that smooth muscle of the vessel and causing it to react, and it makes it easier to palpate, it makes it easier to see, and in reality, we should avoid doing that. For starters, it's often painful depending on who's doing the snapping. And it can also start to initiate some clotting activity. As I said, the reason snapping works is it aggravates that smooth muscle, so that makes the needle insertion more painful. That initiating of the clotting activity is caused by banging on that vessel with the finger, and that can skew test results, especially coag tests. Now, you can certainly use exaggerated palpation. In other words, you can push aggressively, like you're palpating the vein. You found it, but what you're doing is you're stimulating it a little bit, causing it to distend a little bit, but you're not doing that snapping with the fingers. That's something that we should avoid doing. Another one we'll take a look at is a wet massage, and that's really a confirmation. It's not to be considered along with the full arm massage and moving blood, but oftentimes, as Danny indicated, that brain-finger argument that we all get into, where our finger says, there's one, and our brain says, well, I'm not too certain of that. Wearing gloves and then wetting the surface. Alcohol is one that is used frequently because we're going to use that as the antiseptic anyway. And you can actually wet the area, and then by pushing down gently with your finger and moving it back and forth, you can actually feel the top curvature of the vein. You can feel the roundness, you can feel the softness, and that will help you be more confident in the fact that what you are feeling is truly a vein. You can certainly use water, warm water. I'd be careful with that, but again, follow your institutional guidelines and policies, because oftentimes what's warm to us may not necessarily be warm to the patient. In fact, it may be a little too warm. So use that wet massage as more of a confirmation in what I feel is really there. We can also take a look at, we've talked about gravity, but gravity could truly be your friend. So when we want to use gravity, we can use that just like the massage in a couple of different manners. You can actually have the patient raise their arm, and gravity will help reduce that blood flow and move blood back into the antecubital area. But this is primarily a good trick for hand veins, and you could prove that to yourself. You could take a look at your hand veins as they present now, and then lower your arm and have your hand dangle down and hold it like that for a few minutes, and raise your hand back up, and you'll be quite surprised if you haven't used this technique at actually how much gravity can help us in moving blood into the vessels. Oftentimes, gravity alone is all you'll need. You won't need heat or anything else. And then once you've located the vein, you can apply the tourniquet, and you can turn the arm to the normal horizontal position and prepare yourself for the collection.
Heat can be your best friend out there. You apply heat, the vessel will pop up. A lot of times you don't want to even see it or feel it. You apply heat for 3 to 5 minutes, and the vessel will pop up for you. You got to follow your institution's policy on this. Like here at Mayo, we can't use like warm washcloths or towels, things like that. We have to use heat packs, warming blankets. It has to be a controlled heat. So you want to make sure you can wrap the whole arm, you can wrap the whole patient up in warm blankets if it's okay with nursing. You know, if there isn't a reason, like they're running a fever and they don't want to apply too much heat, just stick with the arm where you're going to draw. But give it a good 3 to 5 minutes of warming before you take a look again. Just place your tourniquet again in the area that you have heated, and just repalpate and see if any veins pop up. A lot of times the hand works really good with the hand. You can warm a hand up and a vein will pop up for you. So
yeah,
looking at great technique.
Looking at the differences on when would you use like a warm, dry towel, or a blanket from the warmer. As Danny said, you can wrap the entire arm. That's a technique when you simply haven't found anything, and now you're hoping that using that heat will cause some vasodilation so you can find a vein somewhere. The commercial heat packs, as Danny said, work marvelous on hands, where you can focus that heat on the top of the hand and help that vasodilation distend that vessel and allow you to find the vein.
Combos, put it all together. Use all of it together sometimes. If you have real difficulties, use heat, massage, lower the extremity or the arm. All those things working together, a lot of times a vein will pop up and you'll be able to use it.
Take a look at some equipment. The first one we'll look at is the sphygmomanometer. You have to put that word up there. It's more fun to say than a blood pressure cuff, but that's what we're talking about.
For some people, it's easier to say.
The use of a blood pressure cuff is something that's fairly common. I wouldn't say that it's used on a daily basis, but it's one of those techniques that we can use, and I would say it would be something that wouldn't be a first choice. We would try things like the massage or gravity or warming the limb, but certainly if those fail, follow your institution's policy on how to use them. There's a couple different techniques out there. One of them is just utilization of the blood pressure cuff in lieu of a tourniquet, and CLSI guidelines suggest 40 millimeters of mercury. And so basically the blood pressure cuff is applied, pumped up to 40 millimeters of mercury, and used instead of a tourniquet. Another technique that is often used is taking the patient's blood pressure. Again, depending on the institution, this may involve nursing, but taking the patient's blood pressure, then reinflating the blood pressure cuff to about 30 millimeters of mercury above the systolic reading and allow that pressure to stay for 1 to 2 minutes. So what I'm talking about is, for example, the patient had a blood pressure of 120 over 60, 120 being the systolic number. Reapply the blood pressure cuff and pump that cuff back up to 150 now, and let it sit there for a minute. The thing with this technique is you aren't going to leave that blood pressure cuff on there and then do the blood draw. You would deflate the cuff and then immediately apply the tourniquet and palpate for a vein. And I know these two techniques are not the only techniques to use with blood pressure cuffs, but it'll give you a couple different examples should you decide that you want to try this in locating a difficult vein. Transilluminators. Transilluminators are one of those tools that can certainly be utilized to assist you in finding a vein. And they run the gauntlet from little handheld devices that my personal opinion is it's a confirmation of what I think I felt, all the way up to those with significantly more power. They're typically, they're not a permanent attached device, but they're usually on a stand, on wheels, and those have a much deeper penetration of the light, and the reflection of the subcutaneous tissue and the color variation in the vein will allow the vein to appear as a dark line. And again, depending on the type of illuminator in use, it may appear as a dark line, it may appear as a green line, depending on the type of light that the device uses. The thing to remember about these devices, particularly the smaller ones that are often used in peds, they're not X-ray machines. Their ability to locate deep veins simply isn't there. As I said, a lot of them, especially the handheld units, are more of a confirmatory. for the individual that is having that brain finger argument, saying, there's one, and your brain is going, I'm not so sure, then one of these handheld transilluminators can help with that confirmation. The best area of application for any of these devices is the hand and or lower arm. And again, as I already stated, often these are used more as a confirmation of what you may have already felt.
The pumping of the fist, Tina asked that. Will that skyrocket the potassium? Yes, it will. It'll break down the cell walls. When you pump, after you get the tourniquet on, we have them just hold it tight. If you pump, the cells start banging off each other and the cell walls break down. And there goes your chemistries. It can alter your coags too, they tell us. So we don't want them to pump. We want them to hold a tight fist. We use gauze rolls here in 2x2s. We don't use Band-Aids, so we just have them squeeze on a gauze roll and hold that tight. And that helps pop the vein up too. Thank you for that question.
Yes, that's a great comment. To kind of clarify that, if you've ever donated your blood, they actually give you a little rubber squeeze ball, and they ask you to randomly pump your fist. What we're doing there is we're facilitating blood flow. Keep in mind, we don't have a tourniquet on, and we're not drawing blood for analytical purposes. When we have a patient that's pumping their fist, yes, they're exaggerating blood flow, but we have a tourniquet in place. And what happens is we exaggerate the blood flow. It may allow you to find the vein. This is a perfect example of that. Finding the vein and getting the blood is only half the equation, making sure we have a quality sample sent to the lab. We actually exaggerate that blood flow to the point where, as Danny said, we have a buildup of red blood cells now. Or in other words, we have caused, by allowing this or even suggesting the patient do this, we have caused hemoconcentration. That, in turn, is going to result in us drawing more red blood cells in a given volume, which in turn will increase potassium. It will increase many, if not most, of our electrolytes, our chemistries. We also have to worry a bit about hemolysis because now we're trying to pull way more red blood cells through the lumen of that needle than would normally have been found in that vein because of that fist pumping. So great point.
Seeking assistance, I go to a second phlebotomist. If it's peds, if it's out on the floor, if it's outpatient, I like to have a second phlebotomist come and take a look. If I'm not finding anything, I go right to a second phlebotomist. But sometimes that's not available. It all depends on where you're working at. IV team, sometimes they'll start an IV and we'll get a sample that way. It's just that way. Pediatric RNs, a lot of times RNs are drawing off lines for us if it's peds or if it's out on the floor. We can't draw from lines except for Z lines. But we're working with RNs. There's different areas, but if I have a difficult stick and I'm not finding anything, or I've already stuck twice, and that's our limit here, you can only stick twice and then somebody else has to take a look. But if I'm not finding anything, I go to a phlebotomist to help me. They know what they're doing. They got their techniques, and there's good days and there's bad days. I call them 2-for-1 sales. You come to work and you stick everybody twice to get blood once, and you just got to go to somebody else, and the next day you're out there getting somebody else's difficulties, and you get blood out of everybody. But you're not going to get everybody. Sometimes you just got to have help. So it's a team effort.
Capillary as an option. It really should be a final resort because, as you know, we don't typically get great results. Those of you that have done a lot of capillary collections, I know you get frustrated with the EDTA tube coming back as clotted, and we ask ourselves why. It was, the blood flowed well, and a lot of it relates to the volume of blood in the tube, how quickly we get that tube inverted. Another drawback to capillary collections is we can't draw every single test from a capillary or dermal puncture. For example, coag tests. Aside from the point of care, INRs, I'm aware that we do those. I'm talking about an actual capillary collection for tubes. We don't have any sodium citrate micro tubes. blood cultures, actually any test that requires a minimum amount of serum or plasma for testing that is greater than what our yield would be in a microtube. But we do want to mention capillary options as, another possibility in that difficult patient, especially if it's for a single test, like a metabolic panel, a bilirubin, something with serum. Those seem to be the most test-friendly analytes for dermal punctures or capillary punctures.
Okay, well, thank you, Randy and Danny. At this time, we would like to take any questions that you may have. If you'd like to ask a question through the phone line, you can press *7 to unmute your phone. And then once you have finished asking your question, you can press *6 to mute your line again. Also, you can submit a question via the chat function on CenturyLink web application.
There was one that came through on the UltraTouch butterfly needles with the push button and the larger cannula. Again, we avoid mentioning equipment brands because we don't want to promote anything, but I will say that the knowledge I have of the BD with the cannula, they have recently offered, recognize when we talk needle size, when we look like, say, 21 gauge, 23 gauge, we're looking at the lumen. The actual needle is larger. I do know that BD UltraTouch butterfly, they make a butterfly now in which the material they use, the steel they use for the needle, actually allows them to have a larger lumen opening while still maintaining the strength of the needle. And for example, they have a 25 gauge with a 23 gauge lumen. And so those are certainly things to look at for pediatric collections. Again, I'm aware of that piece of equipment. It's certainly nothing that I would promote, but I do recognize how innovative they've gotten with their cannulas and certainly are viable options for pediatric collections.
What size syringe we use for pediatric draws, that varies. Like PICC lines and central lines on peds or adults even, we try to use a 10 mil syringe. The PSI is less on a 10 mil than a 5. That was hard to believe when I first heard it, but I actually seen it done, and the pressure is less. So if you have a difficult, a lot of times a 10 will work better. We do go all the way down to 3 mil syringes for peds and adults on difficult sticks. So hope that helps.
I'm not sure about the question with the blood pressure cuff after a phlebotomy draw. Recognize, that we should be able to do a blood pressure on the other arm, but I would think that we should wait a minimum of 5 minutes to allow for clot formation. If you're faced with that situation, my advice is do the blood pressure if you know. Obviously, sometimes we don't. But if the nurse needs to do a blood pressure and you need to draw the blood, do the blood pressure first and then go ahead and draw the sample. The one regarding snapping fingers, literally what I meant by that is those individuals that you can hear it. I mean, it's not a gentle pop. They're literally smacking their finger over the vein. This is concerning the question of when you say snapping your fingers over the vein, is it the same thing as using your 2 fingers and tapping up and down? No, that's the difference that I was trying to describe. Some of these techniques are really better visually demonstrated, but the palpating to massage that vein would be a more forceful palpation than you would use to just look for the bounce. However, there is a significant difference between that and the actual popping of that vein by snapping fingers over the top of it. That's what we should avoid.
David asked, what % of your draws are butterflies to straight needles? I don't know if we really have a number for that. it's kind of the technician's choice here, what they really need to use. We try to use vacutainers and syringes, straight needles more than butterflies, but vacutainers is our first go-to device. If it calls for a butterfly, we use a butterfly for difficult sticks, hand veins, large draws, that sort of thing. But it's kind of a judgment call. I can't really give you a number what the percent would be.
Yeah, there certainly exists in most of the supervisors that I talk to in different institutions an overuse of butterflies. And if you think about it, there is concern, and not just from a cost basis. You look at the evacuated system, the blood goes up that short needle and right into the tube. When we use a butterfly, the blood is not only traveling through that needle, but it also is traveling through, depending on what butterflies you use, 6 to 12 inches of tubing into a syringe, which on a dispensing device is attached to, then it moves through another needle. So there's certainly some concerns. A lot of patients ask for them, and a lot of patients are told that by other phlebotomists. The patient will say, wow, nobody's ever gotten me this quick before, this easy, and the phlebotomist will then, some of them will say, well, tell them to use a butterfly. I would encourage you to educate your patients in regards to equipment choices, especially if you're confident you could get it with an evacuated system. A butterfly is a wonderful tool, but it does have its limitations, and there are concerns in regards to specimen quality when we use a butterfly. Can you reiterate the clotting issue with EDTA microtubes? It indicates that they're in their institution. Is it Maxine?
Yep.
Their RNs and some of the techs are having issues with clotting, and it's basically related to dermal puncture. It takes time for that blood collection process to occur. And the longer the delay in getting the minimum volume required in that EDTA tube, between that and mixing that blood and with the EDTA, the anticoagulant in the tube, there will be microclotting that will start. And when that is then analyzed by the lab, they will reject it and ask for a redraw. One tip that I can give regarding these microtubes. So many people look at them and they recognize it's such a tiny amount of blood. And then they happen to get a patient that they bleed copiously. And they say, oh, well, instead of just sending this little bit for them to test, I will send more. Recognize the danger in that. Never overfill a micro container above the line that is the fill line. Because what we're doing, even though we think we're doing the lab a favor by sending them more blood so they'll get a better test, we're actually causing issues in the fact that there's only enough anticoagulant, in this case EDTA, in a green tube, the heparin, there's only enough anticoagulant there to prevent the maximum fill volume from clotting. If we say, oh, I'm going to fill this little tube up, we are actually not doing what we should be doing because there's simply not enough anticoagulant to keep that blood from clotting.
David asks, can you expand on using the entire arm? This is not listed as an acceptable practice under CLSI. We actually go probably 3 to 4 inches above the anacubical fossa area. You got to go with your guidelines that you're following at your institution is the best way I guess I can put it. Randy, you got anything better?
No, and there are areas that CLSI recommends you don't use them. We're not advocating that, you go against their recommendations. And primarily the two big ones that CLSI asks us to avoid is the underside or the actual wrist area, and then again the wrist area concerning the cephalic. Again, I'll apologize for that. We were talking about location of the vein. The cephalic is easy to find in the wrist, but once you find it, you should be able to palpate above or below that and stay away from that wrist area.
Marie asked, which finger is more sensitive to finding and palpating the vein? When we train our students that go through our class, we train them to use either their pointer finger or middle finger on their off hand. Don't use your thumb, that's usually callous more, there is a pulse in your thumb. And try to use the same finger all the time. And one of those two fingers work the best. You just got to try what works best for you and stick with it, and you'll have better results.
Right, index or middle finger works marvelously, and as Danny said, the most important thing is you can actually train a finger. I know it sounds silly, but you'll start to believe in that finger, whether it's your index or your middle. Some people use both. Those seem to be the best ones. However, if you were one of those individuals that could find any vein on any person and you did it with your ring finger, hopefully nobody's telling you not to do that, because the whole key is to find that vein, do one stick, get a great specimen, and send it off to the lab. Everybody's happy. The phlebotomist is happy, the patient is happy, the lab folks are happy, the physician is happy. So really the easiest answer to that is whatever works for you, use it.
Okay, well, we are at the top of the hour here, so we're going to wrap things up. If you did submit questions ahead of time prior to this webinar, we'll work on trying to get some of those answers to you via email and try to get working through those. Excuse me. So I'd like to thank you all for participating in today's webinar. If you do have any additional questions, please indicate them in the evaluation that will be forwarded to you shortly. Note that laboratory credit is extended for this program. Upon finalizing your evaluation, you'll have the option to claim credit and print your certificate. As a reminder, this program was recorded and will be archived on our website in a few weeks. Please visit the education website for more information on upcoming education offerings and a list of upcoming phlebotomy webinars. The next phlebotomy webinar will be on May 20th, 2020 from 11 to 12 p.m. Central Time on blood cultures. Also, please join us for the 2020 Phlebotomy Conference to be held in Rochester, Minnesota, April 23rd through 24th, 2020. Registration is now open. For more information, please visit mayocliniclabs.com/2020 phlebotomy. Thanks again for joining us for today's webinar, and we hope you have a good day.